Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 95 of our Pharmacotherapy MCQ series, which majors in oncology. And our first question reads, to which of the two classes of antineoplastics listed below does bendamustine belong structurally? Is it nitrosourea and pyrimidine antimetabolite? Is it purine antimetabolite and an alkylator? Or is it platinum-based antineoplastic and a nitrosourea? Or is it vinca alkaloid and tangzine? I'll give you 10 seconds to choose the correct answer. So it belongs to the two classes purine antimetabolite and alkylator. Now bendamustine, which is marketed as Trienda, structure wise has an alkylating group which is a derivative of mechloroethamine, and it also has a purine like benzimidazole component to it. Let's move to the next question, please. And it reads, which of the chemotherapeutic agents listed below are cell cycle-specific? Is it Busulfan, DOCEtaxel and Cytarabine? Is it Paclitaxel, Vinblastine and Cytarabine? Is it DOCEtaxel, Elfalan and Carbazine? Or is it Busulfan, cyclophosphamide and vincristine? I'll give you 10 seconds to choose the correct answer. B is the correct answer. It's Paclitaxel, Vinblastine and Cytarabine. Now the cell cycles, as we know them, include GO, G1, S, G2 and M phases, where various cell activities are going on, including protein synthesis, DNA synthesis, and even mitosis, and so on and so forth. Now, Paclitaxel, Vinblastine, and Cytarabine are all cell cycle specific. They may induce their anti-cancer effects only in one of the phases of the cancer cell cycle. That's what makes them cell cycle specific. Vinca alkaloids and the tangzines work in the M phase, whereas antimetabolites interfere with the S phase. Now, cell cycle non-specific agents act independently of the cell cycle phases. Now, alkylating agents such as cyclophosphamide, melphalan, dicarbazine, busulfan are cell cycle non-specific, and the epidophylitoxins are cell cycle specific, just for information, and etoposide is cell cycle specific and it acts on both M and S phases of the cancer cell cycle. Let's move to the next question, please. Oncogenes can be defined as tumor-causing genes which have roles in the development of many cancers. Through gene duplication, addition, insertion, deletion or chromosomal translocations and chromosomal rearrangements of certain proto-oncogenes. Their function is altered and they are converted into oncogenes. These mutations overexpress the protein to an uncontrolled level, which leads to tumor formation. So my question to you is, which of the following isn't non-target inhibited or regulated by drug therapy? Is it VEGF, TPS, EGFR, or is it BCR-ABL? I'll give you 10 seconds to choose the correct answer. TPS it is. Now TPS stands for tumor proportion score, and it's a measurement test to determine the extent of PD-L1 expression in a tumor. It isn't a mutation or an oncogene. Now BCR-ABL is targeted by drugs such as imatinib, dasatinib, nilotinib, bosutinib, and even ponatinib. The EGFR is targeted by elotinib, dacomitinib, ifatinib, gefitinib, and even osimertinib, OSIMERTINIB. And the EGF is targeted by axitinib, sorafenib, and ramucirumab. A difficult name indeed. I would just like to add that various drugs are used to target specific oncogenes or mutations in certain cancers. It is important to be familiar with these common ones, as there are many drugs that act on these receptors as inhibitors. Now, knowing the type of inhibitor can help predict the type of side effects patients will have on these agents. For example, the side effects of the VEGF inhibitors include hypertension, proteinuria, impaired wound healing, and bleeding events. So that can help the clinician make rational decisions. Let's move to the next slide, please. And the next question reads, in the breast cancer prevention trial called the study of Tamoxifen and Raloxifene, abbreviated as STAR, similar prevention of breast cancer was achieved in each arm. So my question to you is, which of the side effects listed below occurred more in the Tamoxifen arm than in the Raloxifene arm? Was it arthralgias, hot flashes, and vomiting? Was it VTE, endometrial cancer, and cataracts? Was it hot flashes, VTE, and endometrial cancer? Or was it endometrial cancer, arthralgias, and VTE? I'll give you 10 seconds to choose the correct answer. It was VTE, endometrial cancer, and cataracts. Now, Tamoxifen, marketed as Nolvadex, and Raloxifene, marketed as Evista, are both SARMs, selective estrogen receptor modulators. Now, Tamoxifen is primarily used for the treatment of breast cancer, whereas Raloxifene is used for both osteoporosis and breast cancer treatment, just for your information. Let's move to the next question, please. And it reads, Mrs. IOJ, a 46-year-old Caucasian female patient, presents to your oncology clinic. She has a past medical history of gastric ulcer secondary to H. pylori infection. She eats lots of fries and hamburgers on a daily basis at fast food restaurants or joints, and she drinks 1 to 2 beers weekly socially. She has a family history of a father who was diagnosed with gastric cancer at the age of 51 years. So my question to you is, which of the risk factors for gastric cancer does Mrs. I or J have? Is it ethnicity, H. pylori infection and alcohol use? Is it ethnicity, H. pylori infection and diet? Or is it H. pylori infection, diet and family history? Or is it H. pylori infection, alcohol use and family history? I'll give you 10 seconds to choose the correct answer. They are H. pylori infection, diet and family history. Remember, H. pylori infection, a diet high in salted, fried or preserved foods and low in fruits and vegetables, and a positive family history are all risk factors for gastric cancer. Remember, gastric cancer is one of the least common cancers in North America. It is rampant, however, in other parts of the world, so for example Asia, and it is more commonly diagnosed in Asian or Pacific Islanders. And it's also highly commonly diagnosed in Hispanics, African Americans, Africans. Therefore, Madam I or J wouldn't be at a high risk due to her ethnicity. Remember, she's Caucasian, if I remember well. Then while a meta-analysis showed a lack of association between moderate alcohol consumption and gastric cancer risk, there was a positive association with heavy alcohol drinking, that is over 4 drinks per day, especially for non-cardiac gastric cancers. Now, Mrs. I or J wouldn't be considered a heavy drinker. Remember, she takes 1 to 2 beers a day. Now, I just like to mention that China has the highest number of newly diagnosed gastric adenocarcinoma patients worldwide. Just as a by the way. Let's move to the next question, please. And it reads, J.O.K., a middle-aged cancer patient, receives high-dose cisplatin, that is at a dose of 100 milligrams per meter squared at the oncology clinic. He receives his antiemetic regimen comprising of palonosetron, aprepitant, dexamethasone 30 minutes before cisplatin. So my question to you is, which of the antiemetic prescriptions listed below should J.O.K. receive before being discharged home on completion of the cisplatin infusion? Is it A, 8 milligrams of ondansetron taken orally thrice daily for the next 3 days? Or would it be 80 milligrams of aprepitant taken orally once daily for the next 2 days? Or plus dexamethasone 8 milligrams taken orally once daily for the next 3 days? Or would it be 80 milligrams of aprepitant taken orally once daily for the next 2 days plus 20 milligrams of dexamethasone taken once daily for the next 2 days? Or would it be D, 10 milligrams of prochlorperazine taken orally up to 4 times daily pro renata when necessary? I'll give you 10 seconds to choose the correct answer. Settle for B, 80 milligrams of aprepitant orally once daily for the next 2 days, alongside 8 milligrams of dexamethasone taken orally once daily for the next 3 days. Now, as part of the delayed emesis prevention regimen, when patients receive cisplatin, aprepitant is continued for 2 days. Dexamethasone should be administered for the next 3 days, and the dexamethasone dose depends on whether they received aprepitant or not. Remember, aprepitant inhibits the metabolism of dexamethasone. Therefore, the delayed dexamethasone dose is reduced to 8 milligrams once or twice daily when co-administered with aprepitant to avoid toxicity. Now, the use of prochlorperazine alone isn't appropriate. It wouldn't be effective at all. Now, the use of ondansetron wouldn't be appropriate since Mr. JOK received palonosetron belonging to the same class, and it is a long-acting 5-HT3 receptor antagonist, so we would be doing therapeutic duplication. It's not recommended at all. Let's move to the next question, and it reads: multiple myeloma is a hematologic malignancy which primarily affects the older population. It can affect multiple organ systems in the human body. So my question to you is, which of the clinical manifestations listed below are associated with this condition, multiple myeloma? Is it renal failure, anemia, hepatic failure, and hypercalcemia? Or is it hypercalcemia, renal failure, anemia, and bone metastasis? Or is it hypercalcemia, anemia, hepatic failure, and bone metastasis? Or is it hypercalcemia, renal failure, hepatic failure, and bone metastasis? I'll give you 10 seconds to choose the correct answer. So the correct answer would be hypercalcemia, renal failure, anemia, and bone metastasis. Now, multiple myeloma may be associated with myeloma-related organs or tissue dysfunction. It also tends to metastasize to the bone. Now, many patients diagnosed with the multiple myeloma may present with clinical manifestations called the CRAB criteria, C-R-A-B criteria, where C stands for hypercalcemia, R stands for renal impairment, A stands for anemia, and B stands for bone metastasis. Now, multiple myeloma doesn't typically cause liver injury. Now, while renal impairment, anemia, and bone metastasis are common or more common in multiple myeloma, to be specific, hypercalcemia is less frequent. Just for your information. Let's move to the next question, please. And it reads: your medical oncologist is treating Mrs. T.T.L, a 67-year-old Caucasian female patient with ovarian cancer using chemotherapy containing Paclitaxel and Cisplatin. So my question to you is, which sequence of administration of the antineoplastics listed below would be the most appropriate for Mrs. T.T.L? Would it be avoid this combination since Cisplatin and Paclitaxel are inactive in ovarian cancer? Or would it be recommended that you administer Paclitaxel first followed by Cisplatin? Or would it be advisable to administer Cisplatin first followed by Paclitaxel? Or is it true that you may administer either agent first? I'll give you 10 seconds to choose the correct answer. So Paclitaxel should be administered first, followed by Cisplatin. Remember, Cisplatin should come after Paclitaxel because the Paclitaxel clearance values were found to be 21% lower when Paclitaxel followed Cisplatin. Now, when Cisplatin preceded Paclitaxel, the absolute neutrophil count nadirs were lower, and grade 4 neutropenia was more common than when the Paclitaxel was administered first. Let's move to the next question, please. And it reads: Mrs. APG, a 57-year-old female patient, was initiated on a fludarabine-based combination chemotherapy regimen for the management of what we call RI stage 4 chronic lymphocytic leukemia, CLL. My question to you is, which of the supportive care medications listed below should be administered in Mrs. APG's case? Is it pyridoxine, leucovorin, Septrin, or amoxicillin clavulanate? I'll give you 10 seconds to choose the correct answer. Sulfamethoxazole, trimethoprim it is. Now, fludarabine is associated with prolonged lymphopenia, and this state puts Mr. APG at a risk for PJP infection up to 6 months from the last dose of fludarabine. I'd like to comment that amoxicillin clavulanate isn't the appropriate choice, and then leucovorin is considered for methotrexate rescue, so it's not the right choice either. Then pyridoxine in the past used to be considered for patients receiving capecitabine, but that's no longer the case, so that's also the wrong answer to this question. Let's move to the next question, please. And it reads, Mrs. AMM, a 67-year-old female, was recently diagnosed with stage 4 squamous cell lung cancer. Your medical oncologist has scheduled her first cycle of cisplatin day 1 and then gemcitabine days 1 and 8 every 21-day cycle. My question to you is, which type of emesis listed below would be of concern in this clinical scenario? Would it be breakthrough and delayed emesis? Would it be acute and anticipatory emesis? Would it be acute and delayed emesis? Or would it be acute and anticipatory emesis? I'll give you 10 seconds to choose the correct answer. It would be acute and delayed emesis. Now, there are multiple types of emesis. Now, all chemotherapeutic agents have the potential to cause acute emesis, which occurs within 24 hours of receiving chemotherapy. Delayed emesis occurs longer than 24 hours after receiving chemotherapy. Now, antineoplastics such as cisplatin, carboplatin, cyclophosphamide, and or the anthracyclines are known to cause delayed emesis. And I would just like to add that breakthrough emesis can occur with any chemotherapy when prophylactic antiemetics don't work effectively. It is possible with this regimen, but is often of secondary concern. Now, for cisplatin emesis, it reaches the peak at 48 to 72 hours according to literature after administration, and it can even last up to 6 to 7 days, so watch out for that. Let's move to the next question, please. And the next question reads, Mrs. NON, an obese 52-year-old female patient, presents to your oncology clinic complaining of an unintentional weight loss. She's lost 12 pounds to be specific over the past 91 days. She also complains of unusually extreme fatigue, vaginal bleeding between her menstrual cycles, and post-sexual intercourse. She had her first sexual intercourse at the age of 13 years, and so far she's had 11 lifetime sexual partners. She has delivered 5 live babies. She's a mother of 5, and she smokes 2 packets of cigarettes on a daily basis and drinks 2 beers daily. So my question to you is, which of the risk factors for developing cervical cancer does Mrs. NON have according to the text above? Is it early age at onset of coitus interruptus, malparity, that is having 5 children, and alcohol abuse and even smoking? Or is it early age at onset of coitus interruptus, large number of sexual partners, malparity and smoking? Or is it obesity, large number of sexual partners, alcohol abuse and smoking? Or is it obesity, early age of onset of coitus interruptus, and large number of sexual partners and smoking? I'll give you 10 seconds to choose the correct answer. The correct answer here is early age at onset of coitus interruptus, large number of sexual partners, malparity, that is having many children, 5 to be specific, and smoking. Now, while persistent human papillomavirus HPV is the most significant risk factor for development of cervical cancer, other risk factors include history of smoking, malparity, oral contraceptive use, early age of onset of coitus interruptus, large number of sexual partners, history of sexually transmitted diseases, even certain autoimmune diseases, and chronic immunosuppression. Just like to add that alcohol use, obesity haven't been associated with risks of cervical cancer. Now, while malparity has been associated with the decreased risk of cervical cancer, it is associated with an increased risk of ovarian cancer due to an increased lifetime number of ovulatory cycles. I would just like to add that prolonged contraceptive use has been associated with a decreased risk of ovarian cancer but an increased risk of cervical cancer. Note that. Then cervical cancer, just for your information, is the 4th most common cancer in women globally, and the majority of these cases, that is 85% to be specific if I remember well, occur in the developing countries. Let's move to the next question, please. And it reads, SKJ, a 51-year-old patient with confirmed stage 2A HER2 positive breast cancer, receives adjuvant trastuzumab therapy every 3 weeks at your oncology clinic. During today's appointment, she has a chief complaint of fatigue and inability to perform activities of daily living. Some of her pertinent labs include an anemia. She has an HB of 9.8 grams per deciliter and the hematocrit is 29%. So my question to you is, which of the treatments listed below would be the most appropriate for SKJ now? Is it true that no erythropoiesis stimulating agents, the ESAs, is indicated? Or is it true that we should initiate iron sucrose at a dose of 200 milligrams IV followed by dapapoetin alpha at a dose of 500 micrograms subcutaneously every 3 weeks? Or should we start epoetin alpha at a dose of 40,000 units subcutaneously weekly? Or should we begin dapapoetin alpha at a dose of 500 micrograms subcutaneously every 3 weeks? I'll give you 10 seconds to choose the correct answer. So it is true that no erythropoiesis stimulating agents, the ESAs, is indicated at the moment. Remember, SKJ doesn't qualify for erythropoiesis stimulating agents therapy because she is in early stage breast cancer. Now, ESSAs aren't indicated in curative patients at all. Remember, this patient isn't receiving myelosuppressive chemotherapy. Now, the use of monoclonal antibodies such as trastuzumab marketed as Herceptin isn't myelosuppressive chemotherapy. Now, since ESSAs have a small but significant risk of disease recurrence and death, ESSA use in curative patients isn't recommended at all. So A would be our best bet in this particular question. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave a comment at the bottom of it. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me, and I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you very much.